So we're gonna ask all our panelists to join. And there's a lot of question, obviously, about metronidazole, fiber, how to taper. So it's all overlapping questions. Maybe a very quick question for you, Jennifer. This question always comes up. Is there a difference, you think, affecting gut microbiota in antibiotics that are given orally versus, parenterally?
That is a great question. And I am struggling. I'm trying to recall if we have, I feel like there have been studies done on that topic, but I'm struggling to recall them to mind. I certainly think that it is prudent to uh, practice as if intravenous or parenteral antibiotics do impact the gut microbiome. I mean, I can't imagine that they don't. We know that they impact, oral antibiotics can significantly impact the microbial populations in other organ systems, right? The respiratory tract, the skin, etc. So even if we're not getting like severely high concentrations, we're still getting quote unquote therapeutic levels into the gut, which is a highly perfused organ. So I certainly would not treat it any differently until proven otherwise.
Well, I guess most antibiotics excreted via bile and then reach the small intestine. So that would be ultimately one way, correct?
There's that too. It depends on the antibiotics. Certainly, our fluoroquinolones and our beta lactams are excreted unchanged via bile. So that's a really good point.
Okay, great. So a lot of questions came about metronidazole and then fiber. So let's start a little bit. Maybe Linda and Patrick, for you as clinicians, do you taper metronidazole? Is there a taper protocol? Or there was a question, how do you taper metronidazole? Or you stop?
I can start. For dogs that have been on it for a very long time, like I'm talking about several months or years, then I try to taper. As far as I know, there's no protocol, but it seems to cause less side effects. Like the case I showed, the last case of Elvis, he had been on metronidazole for several years. When I tapered him, I had tried tapering before. So what seemed to be most efficient is to taper with like 25%, and then you will, if you see some side effects, wait for a while for the gut to stabilize and then continue. So that's what I'm typically doing if I think that the metronidazole has an effect. But for Ebba, who didn't have an effect, she had severe diarrhea despite the metronidazole, then I just stopped after 4 days.
Okay.
Yeah, I don't typically follow I've never thought to taper it, to be perfectly honest with you, but I think what Linda said makes sense if you have a patient who's on it for a very long time to reduce any kind of disturbance associated with stopping it. I will say I was doing a clinical study where we had to have dogs free of antibiotics for the study, and about half the dogs, or 60% or so, came in receiving metronidazole, and we stopped metronidazole. And in most of those dogs, the diarrhea went away when we stopped metronidazole, and we lost a bunch of patients to the study because we stopped metronidazole and their diarrhea went away. That's just an anecdotal observation.
Yeah, so maybe very briefly, because that's a question always comes up, So in one way, we see dogs that seem to respond to metronidazole. Then we see, like Sarah showed, dogs and cats actually had softer stool on metronidazole. How is this all? How does it all work? Because that's maybe the confusing part. What's the mechanism? If it works, what's the mechanism? And
yeah, I mean, I know we reduce the bacterial load when we give antibiotics, so of course we can have less effect of that. And we also know that dogs with chronic enteropathy have an upregulation of toll-like receptors, so they can react more to microbes than a healthy dog would do. So if we reduce the bacterial load, then we can, for some individuals, that can help reducing clinical signs.
okay. Perfect. Fiber, quick question for you, Jennifer. Very quick question. Anything known, those fiber influence somehow the microbiome or farmer microbiome? Any studies there?
Not that I have come across, but I mean, we know we can, I think, induce that we know that fiber influences microbiome structure, right? And so that is going to influence the biotransformative capacity of the gut. I actually was thinking while listening to some of the earlier talks, especially Patrick's, about the idea of well, what would postbiotics? What would we expect postbiotics to do with gut drug biotransformation? Right. That certainly we would expect that to potentially influence the biotransformative capacity of those organisms. So, another thing to study.
Okay.
I think we often, sorry, I didn't mean to talk over.
Go ahead.
We often talk about dysbiosis as just being a change in the number or the types of organisms and reduced diversity. But another facet of it that can occur with or without changes in the abundance of different organisms is the change in metabolism. So some of those studies looking at the, supplementing tryptophan or interfering with tryptophan pathways, the relative abundance of different organisms doesn't always change, but their metabolic capacity or the metabolic pathways that are activated or suppressed change. So you can see significant changes in microbial metabolism without major compositional shifts in the microbiome. So just to throw that in there as another complicating factor.
I think that's also evidenced in the studies that have looked at bile acid metabolism, that sometimes the major change is actually in the metabolomic side rather than the the 16S sequencing, that the effects are actually more obvious when we're looking at the gut metabolism.
Mm-hmm. One important question was always the dose of psyllium. So maybe I think there's little bit different dose ranges in literature. Linda and maybe Sarah, what dose is recommended psyllium clinically and from a research perspective? Maybe Sarah. Yep. Sarah first.
I mean, I've personally, looking at dose responses, I don't typically work in a lot of that, but whenever evaluating diets, we're looking at the fiber content as a whole. And so I'm currently trying to work to target to increase to 10% of fiber, total dietary fiber as a whole. But in terms of a supplement, it's hard for me to say what would be ideal.
So Linda, what do you use clinically?
So I usually start with something like half a tablespoon for up to 10 kilo dog once daily, and then increase to twice daily. If you read the very old GI handbook, Strombeck's, that is available in some places still, they say 1 to 6 tablespoons per day, but 6 tablespoons is really a lot. So the study I cited on police dogs, they gave 4 tablespoons a day. That is quite a lot. But of course, it's quicker to see an effect if you use higher doses. So, but typically I start with half a tablespoon per 10 kilo dog.
And what happens if the response? Are you leaving the dose? Are you playing with the dose?
Yeah, especially because sometimes you can see, even if they respond well, you can see this sort of corkscrew appearance of the feces. It looks really like a string with pearls on. And actually, dog owners often talk about they have problems ending the defecation because the psyllium makes the feces so gluey. So then you need to decrease the dose. So you can try to decrease it to the lowest effective dose.
Okay. Patrick, something to add from a clinical perspective?
No, I think I think Linda, you're a little bit bolder with your starting dose of psyllium. You have more experience in this area. The thing I usually start, if you look at the supplement that I use, on the back, the human dose is a teaspoon, starting with a teaspoon, and then escalating it from there. So I typically start with a teaspoon or so, and then I'll escalate it every few days until I get the effect I want. And then from there, I just kind of let it ride. I don't really mess with, once something's working, I don't see a reason, unless they're having complications, especially something like psyllium that's relatively benign. I don't see a reason to de-escalate once it starts working. So I usually start about a teaspoon for a small animal, maybe a teaspoon or 2 teaspoons for a larger animal, and I'll escalate it from there based on their effect. The thing I worry about it because it gelatinizes and expands significantly in water, that if you feed too much too fast, you can get some gastrointestinal discomfort just from it expanding inside the gastric lumen. So I tend to start small and then kind of titrate up to effect.
Mm-hmm. And maybe we have a comment from one of the audience that's probably it's important to note that the dose depends also on the product. Not every product is pure psyllium, so just be aware of that.
Very good point.
Exactly. One thing that comes to question, dysbiosis. I mean, obviously, we know once you have a shift in the microbiome, either small or large, right? It correlates with a shift in some of the functions, pharmacokinetics. How do we know if dysbiosis is cause or consequence of a systemic disease? That's always probably the chicken egg. Any thoughts about that one?
Is that to anyone in particular?
Whoever wants to take it.
So you're asking what, like, the relationship between dysbiosis and systemic illness?
Well, no, I think we're learning more that obviously GI disease and antibiotics cause, some clear dysbiosis, but we know recognizing that also other, like kidney disease, there's a shift in the gut microbiome. There's also shifts in cardiac disease to some degree. So is this the cause or effect, or do we have to think cause or effect, or can we just also think overlapping? I mean, once it's there, it still affects everything, correct?
Right. I think it takes very specific and large studies to prove causality in that situation, because presumably, the predisposing factors that are going to be whatever they are, whether they're gut microbiome or not, right? Those may be in play for years before that, non-GI disease develops, right? And so I think I think the lesson to learn there is, to be wary, right, of assigning cause or effect. And the first thing to do, right, is to describe the interactions and leave it at that. I mean, it brings into mind to me I've done some looking on, right, there's a link between diabetes and metabolic disease in the gut microbiome, and I've read some of that literature, there in that, in those diseases, they really, I think, have done a good job of showing a link between dysbiosis preceding the development of those kind of metabolo-inflammatory conditions, if you will. But these are from very large studies tracking human children over years and years.
Great. One thing that also obviously is mentioned a lot is the bile acid conversion, right? Jennifer also showed this. It's an important one. We know it's part of antibiotics. Sarah, you have shown it, and also GI disease. So sometimes it takes very long to recover. Are there any strategies to recover Clostridium or Peptocillobacter hydrononis?
I will kind of feel this one. One concept I'm toying with is FMT. Because if you can guarantee from a healthy donor that you can bring that in or bring that back, that's one big proponent. There's still some questions on like the methodologies, whether a rectal is better than a capsule, for example. But that's probably one of like the quickest and most efficient ways, in my opinion. Just kind of based on my personal research. But I'm also not a clinician, so it's hard to put that in terms of practice in clinical terms.
Linda, you do a lot of FMTs.
Yeah, I would definitely support that, especially when we have animals that has been perfectly fine and then they have had to have antibiotics for some reason and develop diarrhea that doesn't go away. Then FMT is really good to help combat that. And we can also see when we measure dysbiosis index that we can bring them back to where they were before after FMT. So FMT is definitely the quickest way to do that, if they respond to it, which most of them do.
Yeah. One question also came up, and you mentioned this, Linda, a little bit. So we don't have enough experience, I guess, but difference in oral FMT versus enema. What are the thoughts?
Yeah, I mean, as you say, we don't have any, as far as I know, we don't have any comparative studies in animals. But I had the opportunity that the GI lab made capsules from our Pseudomonas toxic. So we had his stool as rectal enema, and we also had capsules from the same donor. And we knew he had very stable microbiota. So I was trying to use those capsules to increase the interval between the rectal FMTs in dogs that really required FMTs to have acceptable stool. And it helped slightly with the capsules, but it wasn't at all the same booster effect as it was when we gave rectal enema. And I think it's the dose question, because when we give capsules, we can't give them like 30 capsules. It's not going to happen. They don't want to swallow that many capsules. So I can imagine that's one of the biggest differences between those strategies.
There's some research, some basic research in humans and rodents showing equivalency between oral and administration into the large bowel, but the context is quite a bit different between what they're treating in humans and what we're treating. What they're typically treating in the FDA approved indication for FMT in humans is for C. difficile colitis. And we're not usually using it to treat C. difficile colitis per se. We're using it to treat chronic enteropathies associated with dysbiosis. So I think the context is quite different, and what we're trying to achieve is a little bit different in humans versus the pets that we're treating.
Yeah. As Patrick said, there is evidence from people that the route really doesn't differ. If efficacy is the same, but I guess that is based on the volume you give as well, not just the route.
And some of those human studies were giving like huge numbers of capsules as a loading dose, which I think we would have more difficulty getting away with in our patients, because you can't ask them to do it voluntarily.
Yeah. I think one important thing is probably that we probably know the last 2 weeks, 2 days, is that, you know, one therapy often is not going to work, especially those really chronic cases, but diet is always the primary treatment, right? Is there any supportive, if you would do FMT, what kind of diets would you add to it? Or is it just, do you have any thoughts, Linda? Or is it diet always first and then you add FMT for sure?
Yeah, well, it depends on the age of the animal as well. But and also the dysbiosis index, as I said before, because for the older ones with severe disease, malabsorption, so we have a lot of markers that tells us we have severe disease, including marked dysbiosis, then I don't expect FMT by itself to be effective enough. But for younger animals, well, I try to look at what have they been exposed to before, diet-wise, like similar to Artie's talk yesterday. And is there anything that has been slightly beneficial, or nothing has worked? Okay, then we have to try a totally different principle than they have been exposed to before. But I often do both FMT and dietary trial in animals that are severely affected, just to speed up the process.
Coming back to the diets, which are really important, is the benefits of highly digestible diets. Do they relate to improved digestibility on the microbiome by itself, the nutrients that are extracted and absorbed, or both? So is it the microbiome or is it the nutrients, or is it both? Because I think I guess I would think how I would answer the question, but I'll let you first take a first, try. So how does diet work really?
I'd say it's a combination of both the factors. I mean, the highly digestible diet, you're hoping that the host gets as much as they can from it, and then what the microbes get is whatever the host couldn't, but you kind of plan and you account for that in the diet formulation. So I'd say there's a pretty good chance that you're trying to aim for both of those.
I think it's really challenging to tease apart, and this goes back to the discussion of cause and effect. You know, the gastrointestinal tract and the microbes within the lumen, they co-evolve. They're always in a state of dynamic equilibrium. So I don't think you can make a blanket statement about, for a given type of enteropathy, that a particular type of diet would work. I think it's trial and error, and the literature supports hydrolyzed proteins, novel proteins for most enteropathies, and fiber supplementation for distal gut disease, colitis. But beyond that, what the literature supports, I think it's just trial and error on every patient. And I think, you're feeding the intestinal mucosa, you're feeding the patient, but you're also feeding the microbiota. And I don't think you can, in a given individual, separate those two effects from one another.
Yeah,
it's a wishy-washy answer, but I think it's probably close to the truth.
No, I think I would completely agree with you. I think that is what we really probably have to. And I think it's almost impossible to separate those two, as you said, right?
As
and
much
once
as
it depends on
to.
and the state of the GI tract itself, because they often, I think one thing maybe I want to highlight is that we're really understanding now this malabsorption. There's sometimes we can measure in feces glucose and so on. And the question is, can we afterwards modulate that? Maybe, but maybe it also the severe glucose, for example, is also a mark of severe other disease phenotypes, right? So there's other compounds. So I think the major goal, I think, is to see that many different things happening, and the more severe the change is, probably many different things happening at the same time. So targeting one specific area is going to be very difficult. So that would be my thoughts. Perfect. So maybe as a very final question is, there's a very probably summarize everything. Metronidazole and prednisolone for IBD in cats seems to be the go-to. Maybe one final plea from Linda and Patrick, and maybe from everyone else. What can we do to break this cycle?
Oh,
We discussed it many times, but sometimes it's good to repeat it.
I think for cats, then it's really difficult to give them metronidazole. So it seems to be self-limiting for those. So I think the biggest problem is actually the dogs, because most cat owners don't manage to give metronidazole long-term for cats anyhow. But yes, we've seen so much both today and before that. We know that it has increases the risk of antimicrobial resistance. We know that this can spread within the household as well. So we can actually have a negative impact of vulnerable people in the household. And we know it has a very bad effect on the intestinal microbiota and metabolome. It can take a long time before the metabolome and microbiota recovers from that. And for some individuals, it may be that we give them a permanent damage. We don't know that. So stay away from it as far as you can. I would cite the Swedish guidelines, which is that you only give antibiotics when it's strictly necessary, and no other treatments would be as beneficial as antibiotics. And for GI causes, yes, we know that boxer colitis, that's absolutely an example where we allow it, but otherwise you should stay away from it as much as you can.
Okay.
I just wanted to mention, first of all, I'm jealous that Sweden has such wonderful and conscientious guidelines, but the AVMA and ISCAID do have a lot of resources, primarily focusing on antimicrobial resistance, but there are, tools, handouts, things that they've developed to try to help owners understand the negative consequences of using antimicrobials indiscriminately. So I think that's something that might be useful to some people.
Okay, great. And then also don't forget, we also discussed this year earlier the ENOVAT guidelines, European guidelines for antimicrobial stewardship, and they have recommendations how to use, or guidelines how to use antibiotics in acute diarrhea. So I think these are probably universally accepted nowadays. So that's also something that can be found under the Purina Institute resources. Perfect. So with this, I would like to thank all of you. I would also welcome back Natalia, who's going to give us a few final words.
Thank you very much. It's such an enjoyment to have and follow this session. It was absolutely fantastic. And I know that we are a little bit over time, but I cannot miss this opportunity to express opinion of thousands of people who were following us during these 2 days, during the Purina Institute Microbiome Forum global event. And thank you for bringing questions, such a high, sometimes technical questions, which you can really translate in the messages that each of us can take back and use in a clinical practice. I want to remind you that if you scan this QR code, you will receive in your library a wonderful book that a lot of faculties who were presenting in these 2 days, they were contributing with their knowledge and experience and skills. And not only this, because we know what you as a veterinary and healthcare professionals need, and we really would like help you to keep nutrition in the top of your mind as an incremental part of health and disease management. On the PurinaInstitute.com, you can find various materials that can help you in a different situation, in different level of your expertise, and with different patients. Go in and look for the Center Square, take the book, follow us on social media, and definitely stay connected with the Purina Institute, because much more to come. And the questions we received during these 2 days, I'm sure we were not able to answer all of them. This will be already a base for the next Microbiome Forum Roundtable discussion next year. And Jan and faculty, thank you very much, and all the best.
Thank you so much, everybody.
Thank you.
Okay.